Uh, Good evening, everybody. Today's session is on electrocardiography, a very important component of intensive and something we are not good at because somewhere along the line, I think we miss out on ECGs. Many of us don't get enough postings in the cardiac intensive care and so on and so forth. But it's very important, not only the arrhythmias, but the what we can call the cold ECGs. And for today's topic, we have with us Sir. Sir was my former senior at another hospital in Gurgaon, and I had the good fortune of working with him and learning cardiology and ECG, of course, from him also. He is presently Director of Cardiac Sciences and Interventional Cardiology at Fortis Hospital, Vasant Kunj. And he's written a very nice book on lipidology and has also been awarded the best best cardiologist at the Health Award Summit recently. So I think he'll teach you very well because I know him personally. He has a lot of interest in teaching and academics. And even at that time, he was at the forefront of academics in my previous hospital. So with that, I will hand it over to you, sir. If there are any questions, please put them in the chat box. And maybe I will interact a little in between if there is anything to be interacted about. And in the end, we'll have a discussion as usual. So over to you, sir.
Thank you. I'll share my screen. So thank you for your kind introduction, Dr. Tapesh. I think I made the presentation as simple as possible because, for the uninitiated or who are less, exposed to the daily ECG reading, for them at times it becomes really difficult. So I try to simplify. So I start with the basics. Whenever there is a technology, we feel that what is there? What's now? The other guy says the machine is making a funny noise and the green line is flat. So that's how the machine, that's how with the learning, that's how we advance. And we advance by standing on the shoulders of our joints. That's what Sir Isaac Newton said. And just, taking you to the pages of history, I'll tell you a small story. ECG began with Dr. Wallier, and Augustus D. Wallier first defined the term electrocardiogram, and this is the picture of his first experiment. Before that, the background was there 200 years before his presentation. One physician, Dutch physician, he was not a physician, he was a veterinary surgeon. What he did, he killed a hen by a shock in the head. That means delivering electric current on the head. Then second time, what he did is immediately he delivered a current to the heart of the hen. And then hen got revived and it lived for more than 6 months. It even laid down an egg. So, long back, our ancestors found that you can really deliver a shock, you can make a VF, and then you can give a second shock, you can revive the organism or the hen, and you can get a long life. That's how we began. And many years after that, this Waller's, experiment using mercury capillary electrometer and a toy train at St. Mary's Hospital, London, in the presence of Dr. Inthoven. This was the ECG recorded. These are the complexes, and they're named as V1 and V2 because they were the only ventricular activity recorded at that time. And Dr. Inthoven, a Dutch physician, was later awarded a Nobel Prize. Always we wonder why it is PQRS? Why not ABCD? Nomenclature, actually originally they used for the electric current of the heart A, B, C, D. This is the first initial deflection recorded by Dr. Waller and then modified by Enthoven. And this is the mathematical derivation of the same waves. And they already used ABCD, so they couldn't use for the second time. They had to invent something new. They start with the P wave, because converting Doskert is starting with letter P to identify successive points on a curve. That's why they start with P, Q, R, S, T. Later on, we have U waves. And this is what is called Enthoven's triangle. That means the forces around the heart are, summation of the triangular forces. And he introduced that it gives me a special pleasure to bring the remembrance here that human EKG was first recorded by a London physiologist, Augustus de Waller, who has introduced the term electrocardiogram into science, and that Dr. Thomas Lewis, whose extensive researches have been crowned with such exceptional success, was the first man in England who applied electrocardiography to clinical investigations. That's how we began. And successive years, we have many advances. We have, multiple lead ECG. We have ECG. Then we had Holter. Then we had now the algorithms for monitoring the heartbeat, even cardiac rhythm. And recently, Apple has concluded a trial into 2020 where the wearable devices by Apple have got FDA approval for use for the detection of cardiac rhythm. That's how we advanced. So the graphical representation of electrical activity of the heart is called ECG, electrocardiogram, and the graph paper is called the electrocardiograph. A conduction system of the heart is like, in every house you have electric supply and the water supply. The water supplies are the coronary arteries, and the electrical supplies are the spatial junctional tissues of the heart. And these are the spatial junctional tissue. The initial activation takes place at the sinus node, at the sinoatrial junction. That means in the superior vena cava, right atrial appendage junction is the spatial junctional tissue called SA node. From SA node, it travels to the AV node. In the AV node, there is a physiological delay in the transmission, and then it goes to bundle of E's. And through the right bundle, it goes to the right side of the heart, and for the left bundle, it goes to the left side by two fascicles, left anterior and posterior fascicle. And the terminal fibers are Purkinje fibers. The point to be noted that the heart muscles are electrically insulated structures. And the fibers which transmit the impulses, they are fast conducting, they're like cables. So electrical impulse really passes through this because the transmission velocity is fastest through this. And that's why, anything which is occurring in the A is transmitted to the bundle and downstream. Now coming to the concept of leads and electrodes. An electrode is a pole which records the electrical activity, and lead is a pair of electrode makes a lead. So conventionally, we have three limb leads, lead 1, lead 2, lead 3, three augmented leads, lead AVR, AVL, and AVF, and 6 precordial leads. These are the position of the 6 precordial leads, V1 to V6. Each lead should be viewed as a polar structure, like a camera. So as if you are looking with a camera, and any vector which is traveling towards the positive pole of that lead will inscribe a positive wave, and anything which is going towards the negative pole of that lead will inscribe a negative wave. This is of the law, basic law of the ECG. Will come to that. Lead nomenclature. We have 3 planes in the body: transverse plane, coronal plane, and sagittal plane. And these, sagittal plane leads are 2, 3 AVF, and then coronal plane in augmented leads, and transverse planar V1 to V6. And we have the lead system. First is lateral lead, lead 1, AVL, lead 1, AVL, V5, V6 is the lateral lead, and 2, 3 AVF is the inferior lead, and V1 to V2 is anterior, and V1, V2 is septal, and V3, V4 is anterior, and V4, V5, V6 is lateral. And lead V1 to V4 is anteroseptal. Lead 1, AVL, V1 to V6, extensive anterior. That's the nomenclature of the system. And myocardial infarction in the territory are also accordingly named. But we have less vision towards the back because the heart lies deep inside the thoracic cavity. So we have to reposition our leads to get the electrical activity from the posterior part of the heart. What we can do is we can place V1, V2, V3 in V7, V8, and V9 position. Then we will get the posterior part of the heart. And this is how we get the posterior part. And depending on the leads which showing ST elevation, we can have a nomenclature. And this is this posterior myocardial infarction we have shown by this lead. Right ventricle normally is represented in V1. And one can replace the leads, like on the left chest lead you can place the leads on the right side, V1 to V6, and then you get the right-sided leads. Much more commonly, what we do is we place either V3 or V4 on the right side. You get V3R or V4R. And more than 1 millimeter ST elevation in V3R or V4R is suggestive of right ventricular myocardial infarction. And it is to be noted that right ventricular myocardial infarction does not occur in isolation. Most of the time, it is either associated with inferior wall myocardial infarction or lateral wall myocardial infarction. So it is infralateral or posterolateral with RVMI, like that combination. So it is always wise that in inferior myocardial infarction you record the right-sided lead routinely. Coming to the basic laws of electrocardiography. First point, as I just explained, that anything which coming towards the positive pole of that electrode will have a positive deflection. B is anything which is going away from the positive pole, that is going to the negative pole, will have a negative complex. And it is, in between, some vectors are coming and some are going, will have a biphasic complex. As for example, like 2, 3 AVF, always it is always positive because the heart electrical activity comes from the right shoulder towards the left foot. So that's why you get 2, 3 AVF. And it is coming away from the augmented right limb. That means from the right shoulder, it is coming down. So then AVR always inscribes a negative way. That's the normal electrode position and electrical activity. Now, if you know a single PQRST complex, then you have known the electrical activation of the heart. P wave is because of the depolarization of the atria in response to sinus node trigger event. So it comes from the sinus node and depolarizes the atrium. And the PR interval is the time taken for the transmission of the impulse from the atrium to the ventricle. Main delay occurs in the AV node. This is because of the physiological delay, because the heart wants the rate should not go too high. Even more number of transmissible wavefront are coming or depolarization waves are coming. AV node acts as a gatekeeper. It allows some of the impulses to transmit through it after a delay, and that's the normal delay. So the delay of AV node to allow filling of the ventricles and the control of the rate also. QRS is the depolarization of the ventricles triggered main event. QRS interval is from PR interval is from the beginning of the P to beginning of the QRS. In fact, if we remember PQ, that would be a better way for the PR interval rather than PR. And then QRS is the beginning of the Q to the end of the S wave or the J point. This is the QRS duration. And QT interval from the beginning of the Q to the end of the T wave. Coming to the QRS again, QRS complex is the ventricular depolarization. ST segment beginning of the ventricular repolarization, T wave is the repolarization of the ventricle. And you might get a U wave, we'll come to that. U wave is the repolarization wave of the Purkinje system, and you might get a positive deflection following the T wave. It's called U wave. So P, QRS, and T, and sometimes U. If you remember this P, QRS, and T, then we remember that, yes, this is what is there in most of the complexes in a varying size and amplitude and timing. So this is how it looks. The initial vector passes from the sinus node to the AV node. Activation is this way, from above down. And the Q wave, this is the Q wave from left to right, ventricular septal depolarization. That is the normal Q wave activation. That's why we always get a small Q in lead V5, V6, and lead 1 also we get, small Q. And these are septal Q waves. That's a normal septal activation. Then final depolarization of the ventricles, and it is the QRS depolarization. And finally, the basal part is the S wave. So this is how it, is the activation pattern. So we say that NSR or normal sinus rhythm. Normal sinus rhythm means the rhythm is being generated at the sinus node. It is traveling to the normal conduction pathway and depolarizing the ventricle. So the rate and the rhythm are within the sinus range. That means 60 to 100 beats per minute, and all the complexes are showing sinus rhythm. Very basic rule: to diagnose sinus rhythm, look into two leads, lead 1 and AVR. If P wave is positive in lead 1 and negative in AVR, then sinus rhythm is present. Then comes the rate. Rate is calculated by formula, 300 divided by the largest square, or 1500 divided by the smallest RR rate. So if you can calculate the heart rate and you have seen the rhythm, then you know that sinus rhythm is present, and it is reported as normal sinus rhythm. Ecg paper, very important, on which it is written. I'll just tell you a story. One day, somebody told me that the ink has finished. So, the ECG machine does not have any ink. We must know that it is a thermal paper. It is the electrical activity which moves the stylus, and it hits up the stylus, and the movement of the stylus is recorded on a thermal paper. That's how the ECG is inscribed. There is no ink in the ECG machine. Horizontal axis is the time, and vertical axis is the voltage. One smallest square represents 0.04 second, or 40 millisecond, and 5 would be 5 into 4, 0.2, and again 5 a big square will be 1 second. So one big square, 25 smallest boxes, one small box 1 millimeter. So in 5 into 5, one big box. Horizontal 1 millimeter, vertical is 1 millimeter, 0.1 millivolt, 10 millimeter is equal to 1 millivolt. A standard calibration is 10 millimeter. That means in the ECG paper, you'll get something like this, box like this. And this is very important to understand. With a normal standardization, that means if it is properly damped, there is no over or under damp, then it will have a 90-degree angle of this box, 90 degree here, and smooth here again 90 degree. But if it is over damped, it will be undershoot. That means it will be rounded contour. It is under damped, it will be overshoot. Now, why it is important? You must look into this before you interpret the ECG. if you have an under damping, it will overshoot. That means some of the complexes may be elevated, or you might get more vectors, larger vectors. So it will falsely give a ventricular hypertrophy. If it is undershoot, overdamp, that means the rounded, then some of the contour may be rounded. As for example, ST segment may be elevated falsely in the electrocardiogram because of the underdamping. So we must look into this complex clearly, that this box looks like a rectangle, and this angle is 90° and this angle is 90°. Please remember, overdamped undershoot and underdamped overshoot. This is for the standardization. Normally it is 10 millimeter standardization. We might make it bigger, 20 millimeter, to get larger waves at times. That's for the modification. Rate again, 300 divided by number of big boxes, or 1500 divided by small boxes, or you can just have a rough, if you can have a QRS, and then you can show that the second QRS falling here. Suppose you started from here and the second QRS is here, it will be 300, then it will be 150, here it will be 100, then here it will be 60, and it will be 55, 60, and then here will be 55, and so on and so forth. So by seeing the distance between the RR interval in a regular heart rate situation, one should be able to measure the heart rate, and heart rate should be always per minute, beats per minute. And when it is irregular, then we see for 6 into 10. That means we see 10 seconds multiplied by 6, or we say 6 seconds multiplied by 10. Either way we can do. We have to take a longer interval so that we don't miss. Speed and amplitude. Sometimes we increase the speed of the, normally the ECG recorded as 25 millimeter per second. But in certain tachycardias, certain situation where we want to see the atrial and ventricular activity and relationship, we increase the speed. As for example, in this ECG, in the top panel, you cannot see the P wave. But when you increase the speed to 50 millimeter per second, you can see that P waves are now coming up. So this is how the P wave. So this is clearly resembles 2:1 AV block here. So it's atrial tachycardia with 2:1 AV block, right? So P wave. Normally, the P wave is upright in lead 2 and AVF, biphasic in V1 and V2. It is a smooth contour, and please remember simple rule: 2.5, 2.5. That means P wave occupies 2.5 smallest square in the horizontal axis. That means this is the horizontal axis. 2.5 square. 2.5 square will be 0.1 millisecond, 100 millisecond. That means normal duration is 0.8 to 0.11. So normally it does not occupy 3 small boxes. 3 small boxes means 120 milliseconds. That means the atrium is enlarged. So normally 2.5 in the x-axis. In the y-axis, it will be again 2.5 millimeter. So if it exceeds 2.5 millimeter in the x-axis, then what are the things? Then it is the mitral called P mitrally, or it is called left atrial enlargement. If it enlarges in this direction, that means more than 2.5 square in the y-axis, then it is P pulmonary. So this ECG showing normal activity, say 2.5 in the x-axis, less 2.5 in the y-axis. So it is normal. And normally P wave can be little biphasic in V1, but the negative complex and the positive complexes are less than 1 millimeter either way. And they do not occupy more than one smallest square in either direction, the top or below or in the x or the y axis. And this is again, I'm just telling you that remember two and a half boxes. P wave, 2.5 boxes both ways. Now, this ECG, we can see that the P wave is almost 4 square in the y-axis. So it's a P which is enlarged. What is the cause? This is again, you can see in the B1, the negative complex is much more. And this P represents P pulmonary. Why it is P pulmonary? Because the P waves enlarged and the right axis deviation in the lead one, because S wave is prominent more than R wave, and this is suggestive of pulmonary arterial hypertension. This is nicely seen here. The same ECG you can see here is a very large P wave, almost exceeding even the QRS complex. So this is the QRS, and this is the P, and this is the P. This is the P. 1, 2, and 3 smallest square. So P wave is tall. So if it is more than 2.5 millimeters, this is abnormal, we told. So it is we find classically in chronic lung disease, cor pulmonale, tricuspid stenosis, congenital heart disease like pulmonary stenosis, tetralogy of Fallot, primary pulmonary hypertension. So in the practice of ECG, one should always have a differential diagnosis, not the diagnosis. If you get a P enlargement, think for 4 or 5 causes. So P enlargement is either chronic lung disease or tricuspid stenosis, congenital heart disease like tetralogy of Fallot, pulmonary stenosis, pulmonary hypertension like primary pulmonary hypertension. So we should have a differential diagnosis. And then we can take the history and examine and corroborate with other findings. Please have a closer look at this ECG. This is the P wave, which is more than 2.5 square in the x-axis, and this is the LA enlargement. You can see this is the terminal part of the P in Z1 where it is prolonged. So this is P mitral. We classically seen in mitral stenosis, but can be seen in other causes of LA enlargement also. The criteria is P wave with a broad more than 40 millisecond or 1 small square, and deeply negative more than 1 millimeter terminal in B1 and more than 120 millisecond in lead 1 or lead 2. So this is lead 1 and lead 2 more than 120 millisecond. So again, telling us that the 3, it should not be more than 2.5 square. If it is 3 square, then it is abnormal. That's again showing the basic rule, 2.5, 2.5. Now, this ECG, this is the P wave, very tall, QRS, T, P wave, very small, QRS, T, P, in between in these two. So 3 different morphology of the P wave and high heart rate, tachycardia. So P wave of varying morphology in the same lead with higher heart rate, heart more than 100, suggest multifocal atrial tachycardia. Very important from critical care medicine point of view, because you deal with patients with various diseases, particularly lung diseases, hypoxic patients, large pneumonia, use of beta agonist, theophylline use, electrolyte imbalance like hypokalemia, hypomagnesemia. They all predispose to multifocal atrial tachycardia. The diagnostic criteria are that you should have 3 different morphology of the P wave in the same lead, classically lead 2 and tachycardia. And usually this is a narrow QRS tachycardia. That means QRS duration is 120 less than 120 millisecond. QRS usually 2.5 square. So these are the causes, and why it is important, because in some patients they are reversible. You tone down the use of beta agonists, treat hypoxia, then it can be ameliorated. You don't need specific treatment for the This arrhythmia, you have to treat the acid-base status, electrolyte imbalance, and hypoxia, then the arrhythmia goes. The other important feature is in patients who are chronic lung diseases, this multifocal atrial tachycardia, if it remains for sufficient duration, it is a marker of very high mortality in coming 1 year. 1 year mortality becomes high in these patients if they continue to have multifocal atrial tachycardia. Very important from critical medicine point of view, critical care point of view. Now, please have a close look at this ECG, P, QRS. Here the P is negative. This is the QRS, P negative, QRS, and AVR positive P, AVL positive P, QRS normal, AVF negative P, and other leads have P and QRS. So if the P is negative in 2-3 AVF, that is a low atrial rhythm. So it is coming from the upper part of the AV node junction. And if there is narrow QRS, no P wave seen, then the atria and ventricle are getting simultaneously activated. So the stimulus is coming from the mid part of the AV node junction. This is coming from the lower part of the AV node. That's why you get a negative P. That means the P wave is coming after the QRS. This is the P. This is the P. So these are 3 levels of AV junctional rhythm. Now, this junctional rhythm with hidden P wave, there is no P wave. So this is the inverted P, and this is retrograde P wave after the QRS. When the focus is in the upper part of the AV node, normal slightly short PR in the, or also called coronary sinus rhythm. And when the focus is in the central part of the AV node, you get such activation. Both atria and ventricles are activated simultaneously. When the focus is in the lower part of the AV node, atria are activated after the ventricles, like this. These rhythms are generally called high, mid, and low junctional rhythms. Normally, AV junction has a rate of 40 to 60 beats per minute. And accelerated junction rhythm is more than 60, less than 100. If it is more than 100 beats, we call it junctional tachycardia. You can see that P waves are not seen here, but it's very short PR, yeah, very short here, and there is acceleration. So it's a junctional tachycardia. This ECG may be familiar to all of you. We can see that the atrial activity is not seen in lead 1. In lead 2, again, atrial activity is not seen, some wavering. QRS response is irregular. RR interval is varying. So varying RR interval, absence of the P wave or undulating baseline is suggestive of atrial fibrillation. And sometimes you can get some organized atrial activity, particularly lead 2, 3, and AVF, which show sawtooth pattern. This is the sawtooth pattern. And the sawtooth pattern, the upstroke is sharp, and the downstroke is slurred. Sharp upstroke and downstroke is slurring. So these are 2, 3 AVF showing sawtooth appearance, and this is called atrial flutter. And again, you can look into the V1, we can see that organized atrial activity, and this normally what happens is in atrial flutter, the heart rate is either 300 or 150 or 75, depending on the AV block. So if you have a patient who has a fixed heart rate, say 150, not going either way, then you always think for atrial flutter and try to do a ECG at a higher speed with a higher gain, and then we can decipher the mechanism of the tachycardia. Or say it was 300 heart rate and suddenly it became 150, or suddenly became 75 and fixed heart rate. Then again, we should think for atrial flutter with the heart block. So when you encounter a narrow QRS complex tachycardia, we approach this as a narrow QRS tachycardia, and we want to decipher one by one in a stepwise manner that what is the mechanism of the tachycardia. Narrow QRS means less than 120 millisecond. That means less than 3 smallest square, the smallest boxes. As I told you at the beginning, the QRS complex occupies 2.5 square normally. And 2.5 square means 100 millisecond, 110 millisecond. So if there 3 square, that means 120 millisecond, then it becomes wide complex. So narrow QRS means less than 120 millisecond. So first look, it is irregular or regular. If it is irregular, then either it's atrial fibrillation or atrial flutter with variable block, or atrial tachycardia with variable block, or multifocal atrial tachycardia. These are the 4 differential diagnoses if it is irregular with a narrow QRS. If it is a regular, then look into the P wave. If the P wave is not seen, it is buried inside the QRS complex, it is the Avnrt. Very common in clinical practice. You don't see a P wave, but there's a narrow QRS tachycardia. You give carotid sinus massage or adenosine, it gets reverted. That's what is the classical pattern of Avnrt. If you get P wave, it's regular. Look into the P-QRS relationship. Number of P's are more than the QRS. Then it is either atrial flutter or atrial tachycardia. If P and QRS are equal, then look into RP interval, R to P. If it is more than 70 millisecond, then it is Avnrt. If it is less than 70 millisecond, either it is AVRT or atypical Avnrt or atrial tachycardia. So short RP tachycardia. This is the classical Avnrt. What you see that it is a narrow QRS and there is no P wave seen, but in V1 at the end of the QRS complex, you can see a pseudo R. And this pseudo R is suggestive of simultaneous activation of the atria and ventricles. It suggests AV nodal reentrant tachycardia. So these are the characteristic features of AV nodal tachycardias. Atrioventricular nodal reentrant tachycardia, ECG showing during tachycardia, prominent and pseudo R. See, this is the pseudo R, and this is in the sinus rhythm. There is no pseudo R. It has disappeared once the tachycardia settled. And in the B, atrioventricular reentrant tachycardia, and you can see the atrial activity here. And once the sinus rhythm is established, and you can see that short PR and upstroke showing a delta wave, and this is how it looks. And this is during tachycardia, and this is during sinus rhythm. Atrial tachycardia. And this this is a pre-excited atrial fibrillation, where you can see that some of the complex are narrow, some are little different morphologies, and RR interval is variable. So this is atrial fibrillation, and there is slurring in the upstroke. So it's a pre-excited atrial fibrillation. That means there is there is a bypass tract along with this. So this is actually medical emergency. Atrial tachycardia. This is large number of P waves. The QRS is less than the P wave, and narrow complex. So atrial rate is high, and QRS. So atrial tachycardia with variable AV block.
So just one thing, if you could just explain what is the difference between AV nodal reentrant tachycardia and...
I'm coming. Yeah.
Okay.
Yes. Yes. We'll have. Yeah. This slide. This is what Dr. Tapesh was asking. We just talked about AV nodal reentrant tachycardia and AVRT, atrioventricular reentrant tachycardia. AV nodal reentrant tachycardia is caused by mechanism of two differential pathways in the AV node. Normally, in all of us, or most of us, there are two pathways in the AV node. One is fast pathway and one is slow pathway. And preferentially, the transmission takes place through the fast pathway so that slow pathway transmission does not occur. But if for some reason there is a blockage in the first pathway, then the atria finds that the first pathway is blocked. It goes through the slow pathway, and once the slow pathway transmits the impulse, it activates the ventricle, and by the time ventricle has been stimulated or depolarized, the AV nodal junction has regained its transmissibility. So the impulse again passes through the, up through the first pathway. And as a result, there is a electronic short circuiting, down the slow, up the fast, down the slow, up the fast. And that's how the AV nodal reentrant tachycardia occurs. So that's the classical variety of, tachycardia called AV nodal reentrant tachycardia. But AV reentrant tachycardia, AVRT, on the other hand, is because of a bypass tract. The bypass tract is transmitting from the atria to the ventricle. When the bypass tract, is transmitting retrogradely, the normal during the tachycardial normal transmission comes through the AV node normal pathway and travels up the bypass pathway. It will give a narrow QRS tachycardia called orthodromic tachycardia, as for example this. But if it reverse, it goes through the bypass tract and comes through the normal pathway, then it will give a broad QRS tachycardia because it is a fusion. It takes time through the bypass tract so that the QRS is wider. This is called antidromic tachycardia. So this example, this is a orthodromic tachycardia using a bypass tract. Location of the P wave in the ST segment. These are the P waves. This is the P waves. And if you look into V1, see, this is the QRS, big, this is small, big, small. So QRS alternance and the P wave away from the QRS and no pseudo R pattern in V1. These are signs that it is not, Avnrt, it is not the classical variety. And the faster heart rate, of course, here the tachycardia rate is quite high. So faster heart rate and clearly discernible P wave activity away from the QRS and the electrical alternance, all these 3 points to AVRT. That means a bypass tract tachycardia, this kind of tachycardia. That's coming through the normal junctional tissue, going up through the bypass tract. It is not AVNRT. It is AVRT, atrioventricular reentrant tachycardia, not atrioventricular nodal reentrant tachycardia. I think it's clear.
Yes, sir, I think it does.
This is further saying what we are just, discussing at this moment. Atrioventricular reentrant tachycardia, where you give adenosine, you get a point that it blocks after the V, and AV reentrant tachycardia, you give adenosine, it blocks after the P. So that's how is the mechanism, and you can see this is atrial tachycardia. You given a drug like adenosine, and you can still see the atrial activity, higher heart rate, and clearly you can see these are the atrial activity because the heart is slowed down because of the AV block, and this is the atrial activity, and it's atrial tachycardia. And this is how atrial flutter looks. You're given adenosine. After adenosine, you can see that flutter waves, classical flutter waves have emerged, and from here you are not able to see. And here after adenosine, you could see the flutter waves. So sometimes recording at a higher speed during adenosine administration, narrow Qrs tachycardia, you can know the mechanism of the tachycardia and type of tachycardia so that it helps in the management.
Sir, adenosine can lead to cardiac standstill also?
No, it does not. Usually it's reversible. Very rarely it causes, it's little prolonged PR, transient bradycardia for few cycles, then usually comes. So you should not be afraid to give, adenosine in any patient, unless there is a AV block or something, So if it's a narrow Qrs tachycardia, then you can just go give it. Nothing happens.
And the conversion rate is how much for your what we call PSBT?
Most of them, they convert. Most of them.
Right.
Yeah, majority will convert. But some of them, they recur. There'll be 10 to 20% recurrence rate in the same sitting, but most of them, they revert and they don't come. 90% of the time, they don't come.
Right.
Yeah. This is how it looks. It's a very rapid heart rate. You give adenosine, you slow down, and you can see the fibrillatory waves. Coming to the PR interval. PR interval corresponds to the time it takes for the impulse to travel from the AC node to the AV node. And normal PR interval is, again, 120 to 200 millisecond. That means, 3 to 5 smallest square. So I always try to remember in this way. It is better to remember the ECGs by smallest squares. So PR means beginning of the P to the beginning of the QRS. So it is like PQ, and it should be 5 smallest squares. And 3 to 5. If it is less than 3, this is a short, PR. If it is more than 5 smallest, this is prolonged PR interval. And prolonged PR interval means this first degree AV block. That means the transmission of the impulse from the sinus node to the AV nodal junction is delayed. Now coming to the AV block. So first is first degree AV block. That means PR interval is prolonged. But P and QRS always there. If you say the P is the husband and the QRS is wife, the husband comes every day home. P, QRS, P, QRS, P, QRS. Here, in the second degree, Mobis type 1, P, QRS relationship is there and is prolonging. And the husband is coming delayed home. And on weekend, he doesn't come home. This is what is the second degree AV block, Mobis type 1. And he's predictable. That means every fourth complex, the QRS is dropped. And the largest PR occurs just before the drop QRS. So P, QRS, T, P, QRS, T. And this PR is more than this PR. Again, in this PR, much more prolonged, followed by a normal QRS, T wave, and this is P, no QRS. So one P is not transmitted. Mobis type 1 AV block. This is, is a relatively benign, and it doesn't need any treatment. There is no management required. But as opposed to this, here, normal P, every day he comes home right in time, suddenly he doesn't come. This is unpredictable as husband, right? This is second degree Mobis type 2. And this patient requires a pacemaker because sometimes all the P's may not be coming and the patient will have syncope. So this is Mobis type 2 AV block. And this is the third degree AV block where P and QRS are independent. Normally, the number of P waves are more than the QRS. And there is no constant relationship with the P and QRS. PP interval and QRS interval are same. So if you measure from these R and R, they are equal, P to P are equal. So these three are first degree, second degree, third degree AB block. Just to repeat, first degree AB block means prolonged PR interval, benign, nothing to be done. Second degree AB block has two types, MOBIS type 1 and type 2. Type 1 means gradual prolongation of the PR interval leading to one dropped P wave. And this recurs, and this is a predictable pattern. But the second degree AB block, one of the P is suddenly dropped. One of the P suddenly fails to transmit to the QRS. There is no QRS. And this is a situation where pacemaker is required. Third degree AB block, again, we need to treat these patients. The number of P's are more than the QRS, and there is no relationship between the P QRS, and this is called AV dissociation also.
Sir, any role of atropine here? Anywhere?
Yes, atropine you can give in the third degree AV block, you can give a atropine, and you can see sometimes, in particularly when inferior wall myocardial infarction, along with this, it is because of increased vagal activity, atropine treats this. Maximum you can give, 2 milligram of atropine. More than 2 milligram does not help, it causes toxicities, and it causes urinary retention in the elderly also. So if it is a reversible cause, once the bradycardia one, always we can give the atropine. Sometimes it reverses. But then we should look for the cause and treat the cause.
Yes. So we can give it while we are getting ready for the TPI also, like in the emergency situation.
Yes.
Right.
Yeah. We should get ready for the TPI. In the meantime, you can give a shot of atropine. Qrs axis. Normal axis is between -30 to +90 degree, and it produces 2,3 AVF negative. So if the 2, 3 and AVF are all positive complexes, then it is normal axis, -30 to +90. Left axis deviation is between -30 to -90, and right axis deviation is +90 to +180 degree. In the axis between -90 to 180 degrees, no man's zone, and the causes are different for the left axis, right axis, and no man's zone axis. Normally, the left axis deviation we get in past myocardial infarction, left ventricular hypertrophy, emphysema, hyperkalemia, WPW syndrome with the right-sided pathway, tricuspid atresia, ostium primum atrial septal defect, left axis deviation. So these are the causes, various causes. And the right axis deviation, these are the various causes: right ventricular hypertrophy, chronic obstructive pulmonary disease, previous anterolateral MI, left posterior fascicular block, pulmonary embolism, WPW, left-sided pathway, atrial septal defect, pectus excavatum, dextrocardia, and lead reversal. How to read what is the axis? We choose a perpendicular axis, say lead 1 and AVF. Look into the lead 1. If the lead 1 is positive, that means it is coming towards the positive pole. And if the lead AVF also is positive, that means it is coming to the positive pole. So it is coming towards the camera. Vector is coming to our camera in this direction. That means it is normal axis. And if it is positive in lead 1, but negative in AVF, it is going towards the left axis deviation. And if it is negative in, say, lead 1, it is going towards this, and positive in lead AVF, it is right axis deviation. If it is negative in lead 1 and negative in AVF, it is going towards the no man's zone. No man's zone means emphysema, hyperkalemia, lead transposition, ventricular pacing, ventricular arrhythmia. So this zone axis is abnormal. As for example, this ECG, we can see, take the lead 1, it is negative. Lead 1 negative means it is going towards this side. And AVF is positive, that means this. That means it is a right axis shift. So this ECG, right axis deviation. So this is the nomenclature of the complexes. So how to really communicate to your colleague over telephone and how to write that in the ECG. So predominant complex in positive is R wave. First initial positive and followed by small negative is RS, small s. Small means less than 5 millimeter. R means 10 millimeter at least. More than 5, yeah. So small r, deep S. Again, here initial vector is negative, small q, positive R, and again S. QR, negative deflection, and again positive deflection. Both are negative. QS, QR. Triphasic complexes, R, S, R dash pattern, R dash. The second R is called R dash. QR, notching. This is called R with a notch. R dash, that means initial positive deflection, small r. Then there is a negative deflection, but it does not qualify to be called S wave because it is not coming below the baseline. So we call the next wave as R dash. So R dash. And these are the fragmented Qs complexes. We must sometimes say splintered Qrs. Sometimes we say non-specific intraventricular conduction disturbances, right, as IVCD, intraventricular conduction disturbances. Qrs width is, three smallest, less than 3 smallest square. Again, 2.5 is the criteria. So 2.5 means 100 millisecond. Qrs 100 millisecond or less means it is getting activated by the normal junctional tissue and it is coming from above. Broad Qrs, that means if it is more than 100 millisecond, that is occupying three smallest squares, that means say 110 or 100, more than 100 millisecond, 110 or 120 millisecond. That means Qrs is wide. Wide Qrs means we have to have a differential diagnosis. And wide Qrs.
You want to have a glass of water and some 5-minute break? Or is it okay? I can, up to you, sir, if you want to just stop for 2-3 minutes.
Yeah, we can stop here for a while, 2-5 minutes, you can discuss something maybe.
Yes, I will, you can take rest, I will just try to fill in.
Yeah.
So friends, I'll go arbitrarily. I'm sure sir has covered some of the things and some he'll be covering. Just to give him a rest, he has been speaking for 1 hour and it gets tiring. So first of all, you see, ECG is something which is quite specific and less sensitive, meaning that if it is picking up something, then it is actually there. But if it is not picking up something, that does not mean that that particular feature is not there. For example, if the patient actually has left ventricular hypertrophy, then if the ECG is not picking up any left ventricular hypertrophy, does not mean that the patient does not have LVH. But if it is showing LVH, then it means the patient has LVH. This is a general rule. Of course, for something like MI, it is very rare to have a normal ECG. It can be there, and you can have a normal ECG very rarely with acute myocardial infarction. The diagnostic test for MI is troponin I. You have to have 2 sets with a rising trend over 6 hours. ECG does not have to be abnormal as far as the criteria for the diagnosis of MI is concerned. You should all know that it is tropi, which is diagnostic. And then there are other features which may or may not be there, but 1 or 2 have to be present. You should look this up. Then you should check the quality of the ECG. That is whether your electrodes are all right, whether there's any limb lead reversal, whether the V1 to V6 electrodes are placed properly. It is very common for the nurses to put the electrodes improperly. And there should be no artifacts. Sometimes there are artifacts, there are some vague lines coming here and there, which can simulate MI or some other abnormalities like a bundle branch block. Sometimes there is shivering. Shivering can produce something like a VT also. So you should be aware of this. Then T waves are normally present in certain leads only, but they can be present in other leads also as a physiological variant, and their significance has to be interpreted because there can be non-specific T wave changes, there can be persistent T wave changes which are physiological, or they may indicate cardiac physiology or pathology. Then what is a tall T wave? A tall T wave more than 10 small squares on the x-axis in V1 to V6. So that is actually a tall T wave, and you should know the causes of tall T wave. The causes I'm not listing. Sir may show or may not show, I don't know, but you should go through the causes because it is diagnostic for that particular condition. For example, you get tall and tinted T waves in hyperkalemia. It is one of the earliest features, and tinting because the duration of Qrs shortens in hyperkalemia. Just to give you an example of tall T waves. Then what is low voltage? So low voltage is less than 5 squares, small squares on the x-axis in the limb leads, and less than 10 small squares in the precordial leads. So again, you have to know the causes of low voltage ECG. For example, cardiac tamponade or pericardial effusion will have low voltage, and it is understandable because the surface of the chest is what picks up the current, and the fluid around the heart acts like a insulation. So obviously the voltage will decrease. Similarly, in obesity, thick chest wall, etc., etc. So you should know the causes of low voltage, just like tall T waves. Then LBB, RBB, I'm sure sir will show that. You should know diagnostic criteria. There are specific diagnostic criteria for LBB and RBB. Then what is the transition zone? You see, as we go from V1 to V6, the R wave increases in height and the S wave decreases, right? So at around V3, V4, the transition where the R wave becomes bigger than the S wave. So that is what is the transition. And this transition is important. If it is not transiting here, that means there is a problem somewhere in your ECG. Then coming to ST elevation. So ST elevation does not mean STEMI. I mean, it can mean or may not mean. There are various causes of ST elevation, and you should know them again. Then coming to Takasobos cardiomyopathy, something which is become a entity which we are recognizing more and more. It was not there earlier. And patients, for example, there's a patient who came out of the surgery, out of the OT, and by the time he came out, he was in cardiogenic shock, and the EF had dropped, and there was no classical apical ballooning also. So this patient ultimately reversed, and the angio was done. There was nothing on the angio. So this was actually Takasobos cardiomyopathy due to the surgical stress. So just to give you an example. So in what happens to the ECG in Takasobos cardiomyopathy, you can have elevation or depression, T wave changes which revert to normal after the episode subsides and the patient recovers. Then there is something known as early repolarization. So I will leave it to sir to explain.
Yeah, I think I'll take it from here. Yeah.
So I think we'll let sir continue now, sir. Please, I'll hand it over.
Yeah. Thank you so much. So you were talking about the QRS duration. So Qrs duration, if it's prolonged, then you should have a differential diagnosis. So Qrs duration prolonged means the ventricular activation is delayed. So either it is because of the right bundle branch block or left bundle branch block, or it is because of intraventricular conduction disturbance called IVCD. That means it is not cannot be classified as either RVP or LVVB. We call it IVCD, intraventricular conduction disturbance, or it is pre-excitation, or it is severe myocardial disease producing prolonged, ischemia or a terminal event. So Qrs prolongation is very important, and we must be able to diagnose and classify it. First is bundle branch block, right bundle branch block. Right bundle branch block means the activation in the right side of the heart is delayed. So the heart gets activated from the left side. So the initial vector remains fine, so that you get the small Q waves in the septum and everywhere. Then you get small R, and then followed by a prolonged R waves. So you get R and then S and then R dash, RSR pattern in V1. In V6, you get slurred S. So this is the classic pattern of right bundle branch block. When the QRS is prolonged, at least 120 millisecond, we call it complete right bundle branch block. When it is narrow, less than 120 millisecond, we call it incomplete right bundle branch block. Right bundle branch block is a relatively benign phenomenon. We actually should be talking about right bundle branch block pattern rather than right bundle branch block. So RBB pattern you get sometimes in a familial form called familial or congenital right bundle branch block, at least seen in 5% of the families, and it runs in generations. It is not associated with any shortening of the lifespan remains same. So congenital RBB well known. In acquired RBB is because of diseases. These are right ventricular hypertrophy, pulmonary embolism, ischemic heart disease, rheumatic heart disease, congenital heart disease, myocarditis, cardiomyopathy, and Levis disease, that means sclerodegenerative disorder, pen conduction disturbance. And this is how it looks in V1. It looks, taller right rabbit ear pattern. That means this is a rabbit ear, they are equal normally. But in RBBB, in V1, the right-sided one is taller right rabbit ear pattern. But in a tachycardia situation where there is no P wave, when you get a taller left rabbit ear pattern, that is a VT. So we should remember in right bundle branch block, taller right rabbit ear pattern. Left bundle branch block, Qrs duration 120 millisecond, and activation takes place from the right side because the left side is blocked. And as a result, you don't get the septal Q waves. Septal vectors are absent in V5, V6, very classical. And QRS is prolonged. Terminal leads like lead 1, AVL, or V5, V6 will show M pattern or notching. The dominant S in V1 and broad monophasic R in lateral leads, absence of Q waves. So these are the criteria. Classically, we say M pattern in lead 1, AVL, V5, V6. So that's how we recognize. We get in severe aortic stenosis, ischemic heart disease, systemic hypertension, and left bundle branch block. Mostly this is pathognomonic of some disease, and we should be careful about the patient. LBB means there is some abnormality, and we should find out that. Dilated cardiomyopathy, anterior MI, sclerodegenerative conduction disturbances, hyperkalemia, digitalis toxicity. So this is how it looks, again showing that in right bundle branch block, the activation is from the left to right, so that initial Q remains, the slurring occurs at the terminal part. The S wave is prolonged and you get a prolonged R wave, R-R pattern. But however, in the left bundle branch block, the septal activation takes place in the opposite direction from the right side to the left side. That's why you don't get the septal Q waves. Normally, small Q wave is present in V5, V6. Here it is absent, and you get a prolonged initial prolongation. That's why it gives in V5, V6. It gives a M pattern. left anterior fascicular block and left posterior fascicular block. This is usually recognized by two things. One is, axis, and second is morphology. Normally, left anterior fascicular block, you get left axis deviation, small r, dip S in 2-3 AVF, small q, big R in lead 1 and AVL, small q, big R. So this is called left anterior fascicular block. In left posterior fascicular block, you get small r, deep S in lead 1 and small q, big R in 2-3 AVF. So reverse of this. So it is left posterior fascicular block. I repeat, in left anterior fascicular block, you get small q, big R in lead 1 and AVL, small r and deep S in lead 2-3 AVF, and left posterior fascicular block, you get small r, deep S in lead 1 in AVL, and small q, big R in 2-3 AVF. Now, let's look into this ECG. So this is the P wave, this is the QRS, this is the T, P, QRS, T. However, there is slurring the part of the T wave. That means the terminal part of the QR is prolonged, and this P is prolonged, P-R interval is prolonged. And if you look into the V1, there is triphasic wave, R dash pattern, R dash, and V6 slurring of the S wave. That means it is complete right bundle branch block. If you look into 2-3 AVF, small r, deep S, look into lead 1 and AVL, small q, big R, small q, big R. That means right bundle branch block, left anterior fascicular block, and prolonged PR interval. That means this patient has trifascicular block, right bundle branch block, left anterior fascicular block, and prolonged PR interval or first degree block. This is called trifascicular block. Coming to white QRS tachycardia, very important in critical care medicine. By and large, whenever there is tachycardia, if the tachycardia ECG is showing QRS duration more than or equal to 120 millisecond, please remember that it could be VT. And if you do not understand, treat as VT. If you do understand, then let's go ahead. So it is regular or irregular? If it is irregular white QRS, then either atrial fibrillation in WPW or atrial fibrillation with bundle branch block or atrial fibrillation with aberrant conduction, or atrial flutter with variable AV block or atrial tachycardia with variable AV block with bundle branch. So these are the 5 differential diagnoses. So irregular heart rate really tells us either atrial fibrillation or atrial tachycardia with aberrancy. If it is a regular one, then look into AV dissociation. If you get AV dissociation, it is ventricular tachycardia. And if there is AV dissociation, however, the P waves are much more than the QRS numbers, then this is either atrial flutter or atrial tachycardia. Then AV dissociation, no AV dissociation. That means either is AVRT or it is a QRS morphology. It is probably SVT with aberrant conduction, and based on the morphology, we should proceed. We have some stepwise approaches, and before the stepwise approach, we can just look into the ECG and tell it's VT or SVT. If you get 2-3 things, one is if you have AV dissociation, that means there are A waves which are seen like this. Lower panel, you can see that P wave is seen, QRS, and there is a P wave. So clearly this is VT. If you get capture complexes, a capture complex occurs from the production of a ventricular complex by a supraventricular source in the cardiac cycle after AV dissociation for the atrial to regain control of the ventricle. So narrow QRS, suddenly one of the QRS becomes very sharp, narrow. Or if you get a fusion beat occurs when sinus and ventricular electrical impulses coincides. That means they're coming together. That's why you get larger than these ventricular complexes, sharp and large. So this is called fusion beat. So if you get these 3 things, either AV dissociation or a capture beat or a fusion beat, then it is really ventricular tachycardia. It's a very hard criteria, and it stands even with the electrophysiological tests also. So here, just for example, you can see P, this is P. So white Qrs tachycardia, some of the POFs are seen. So AV dissociation with white Qrs tachycardia, treat this as a VT, and this patient has VT. Fusion beat, one of the complex is narrow suddenly, and it is in between morphology with the VPC and the white Qrs, then again VT. Capture, very sharp, narrow, conduction suddenly one. Again, white Qrs tachycardia continuing. So either this fusion and capture beat suggests an VT. Suppose you could not pick up any of these three, then we have to go and use algorithm. Commonly, we use Brugada algorithm. So look into the precordial leads first. No precordial leads has both R and S wave. That means absence of RS complexes in any precordial leads. So if there's absent, then this is VT. Not, then you go to the second step, onset of the R to the end of the S wave, any of the V1 to V6, if it is more than 100 millisecond, then it is VT. If not, look into the AV dissociation. AV dissociation present, VT. If not, then go to the next criteria, morphological criteria. In VT, in morphology is like this, biphasic complexes in V1, R complex, small r, big R, small s, or QR pattern, or QS pattern, or any of these variation. However, in SVT, you get a triphasic pattern, RS, RDS pattern, or QR pattern, and the QS pattern, but then QS is sharp, not 100 millisecond. So if you get any of these criteria, then you are done. But in any case, if you're not able to decide is SVT or VT, please treat this as VT. Remember, ventricular tachycardia can be killing.
So I may add to that if I'm correct, 85% of regular white Qrs tachycardia is VT. If that's
yes, majority of VT.
Sir, one more question this is for this thing. We all know that VT is supposed to be regular, but literature also mentions at times it can be irregular. So do you want to make any comment on that, sir?
No, usually it's regular. Irregularity is because of some fusion or capture, some cycle length variation, but VT is regular.
Right.
VT is regular. Yeah.
Right.
Yeah. So this is, again, RR complex, and this patient has criteria for meeting, absence of RS complexes in the precordial leads, and this is narrow. This is actually SVT, not VT. This patient, see white Qrs tachycardia, RR dash in V1, and prolonged slurred wave, and there is no RS transition, and this is a ventricular tachycardia. Low voltage ECG, you just heard Dr. Tapesh telling us low voltage. This is a classic example. That means in the limb leads, the amplitude of the QRS is less than 5 millimeter. In the precordial leads, it is less than 10 millimeter. That means there is something which is obstructing the electrodes to register the electrical activity of the heart. There is some obstruction. So these could be fluid, like large pericardial effusion, or could be a large pleural effusion on the left side, or patient may be having obesity, emphysema, or could be a large pneumothorax, or could be infiltrative disorder, myxedema, myocardial disease, restrictive cardiomyopathy, constrictive pericarditis, scleroderma, or patient might have had a previous myocardial infarction, so that heart is really severely damaged, or it's a severe end-stage heart disease like dilated cardiomyopathy. So once you get such ECG, please have a differential diagnosis. Please do not give any diagnosis without seeing the patient, without examining the patient, because ECG has to be interpreted in the clinical context. It per se cannot give you diagnosis. History, examination of the patient, and the ECG combined, you get the diagnosis. This is, you see, large R wave in the precordial leads, ST depression, T inversion, lead 1, 2, 3 AVF, showing ST depression. So this is large precordial waves, the R waves and deep S waves. Classically, this is ventricular hypertrophy, left ventricular hypertrophy. So for the left ventricular hypertrophy, we have several criteria. Actually, the cardiologist has to remember there are 6 criteria, 6 sets of criteria. But for all of you, if you remember the commonly used criteria of Sokolow-Lyon voltage criteria, which mostly we use, is S in V1, SV1, or a plus R V5 or 6, which is the tallest. If it is more than 35, then left ventricular hypertrophy is present. I repeat, S in V1, tall R in V5 or V6, anyone which is larger, combining should be 35 or above, that is left ventricular hypertrophy. The supporting criteria are left atrial enlargement, ST depression, T inversion. All these are supportive of left ventricular hypertrophy. And in the precordial leads, you can use, in single lead, say R wave in V4, V5, V6, single is 26 millimeter, or the S wave, say S wave in V5, V6 is more than 35 millimeter. Again, this is voltage, or largest R in precordial leads and largest S in any leads, 45 millimeter. Again, you have the voltage criteria. And ventricular activation time, from R wave peak time, if it is more than 50 milliseconds, it supports the diagnosis of left ventricular hypertrophy. So once you get left ventricular hypertrophy, then we should look for the diseases which can cause, as for example, it could be a hypertensive heart disease commonest, then you get in hypertrophic cardiomyopathy, aortic stenosis, and so on and so forth. Right ventricular hypertrophy. Look into the right ventricular lead V1. If the V1 is a positive deflection, more than 7 millimeter, then it is right ventricular hypertrophy. And usually it is associated with right axis deviation. And typical appearance also suggests that, dominant S in V6 and depth is more than 7 millimeter. And right ventricular stain pattern, that means in V1, V2, V3, you get T inversion, sometimes ST depression. These are secondary to the right ventricular hypertrophy. So, the causes would be, again, various causes of pulmonary diseases and including pulmonary embolism, etc. And sometimes you might get a ECG like this. And this is very interesting. You see the QRS, QRS is less tall, here is taller. Again, it becomes smaller. Again, this is the lead 2, where you can see that one is larger than the other, alternating small and larger. Yes. So electrical alternance. And electrical alternance suggests that there is something ongoing, and typically it occurs in large pericardial effusion, and it suggests that if there is a total alternance, that PQRST alternance, it suggests tamponade. So this is how it looks, electrical alternance. And you might get this electrical alternance in severe myocardial disease also, like pulsus alternance. R wave progression and R wave regression. Normally, the R wave becomes larger as you move from V1 to V6, and transition zone is in between mid-precordial leads, V3 and V4. If your R wave height is not 5 millimeter or more in say V3, then we call it poor R wave progression. That means the R wave is not increasing in height, then it is abnormal. And normal R wave progression, you can see the example, V1, V2, V3, the R wave is becoming taller and taller. Here in V1, V2, V3, the R wave remains small. And in V4, it becomes little, and V5, it becomes the tallest. Again, V6, it regresses. So here the R wave progression is lost. So absence of R wave progression you get in old or new anterior myocardial infarction. Again, we have to have set of diagnoses, differential diagnosis, lead displacement, frequently misplaced lead, left branch block or left anterior fascicular block, left ventricular hypertrophy, WPW syndrome, dextrocardia, tension pneumothorax with mediastinal shift, congenital heart diseases, or COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease with a clockwise rotation, the transition zone will shift toward V5 or V6. Normally, it should occur between V4 and 5. Was talking about transition just now. 70 years gentleman presented with these ECG changes, new ECG changes, you can see. So look at the V1, V2, V3. Here, the R wave height is lost. So it's anterior myocardial infarction. This is the ECG at presentation. This is the chest X-ray at presentation. Gentleman presented with chest pain. And you can see large pneumothorax. The transition zone is gone to V6. R and S is in the V6. Up to V5, you don't have really R wave. And intercostal drainage was placed, air aspirated, lung expanded. You can see the reappearance. V4, R and S, V4. So after the treatment was done, pneumothorax was treated, the transition zone is seen in normal place. So this is an example of a large pneumothorax producing a transition zone in the lateral side because of the clockwise rotation. ST segment, very important. Please remember in the ECG, there are 3 isoelectric points. One is TP segment, next is PQ segment, and the next is ST segment. Any deviation of these 3 isoelectric lines is abnormal. So ST segment deviation is always abnormal. And very rarely you might find ST elevation, that is called, early repolarization abnormality. And this is relatively benign, although there are some, increasing evidence of myocardial abnormalities and slight increase in sudden death in these individuals in the long run. But by and large, early repolarization abnormality is benign, also called male type ECG pattern. That means you might get a, J point elevation and ST elevation in the precordial leads or lateral leads. So normal ST segment,
this is quite common, sir. Actually, this
quite common, but a lot of research is going on. So this is now viewed as under research.
Yes.
Yeah. Most important causes of ST abnormality is myocardial ischemia or infarction. And this is the J point. J point elevation is always accompanied by ST elevation, and always we should look into the J point elevation also, J point depression also in depression. So this is how it looks in J elevation, J depression, and ST depression. Now, again, when the ST is elevated, you have to have a differential diagnosis. There are some systemic disorders, some conduction abnormalities, some pericardial disorder, they might cause ST elevation. So the most ominous is myocardial infarction, ST elevation, myocardial infarction. And this is very important from the critical care point of view, because we know that if you get a patient with ST elevation, And if it is because of myocardial infarction, we must diagnose this patient and we should deliver reperfusion therapy, because in STEMI, myocardial reperfusion either by a thrombolytic therapy or a primary angioplasty saves more lives. So we have to triage this patient ST elevation because of myocardial infarction. So we should really know it. Takasobos Cardiomyopathy, called stress cardiomyopathy, also here we get ST elevation, and classically there is some stressful situation, coronary risk factors are absent, and we get apical ballooning and this patient, and this is a reversible form, and usually the LV becomes better over time, but the initial management is like myocardial infarction, and we should treat this as also as a acute illness. Then you get left ventricular hypertrophy or a large LV aneurysm because of the previous MI. Conduction disturbances like left bundle branch block, early repolarization abnormality may give rise to ST elevation. Acute pericarditis or pneumopericardium may give rise to ST elevation. Systemic causes are electrolyte disturbance like hyperkalemia, hypercalcemia, acute pancreatitis. Acute pancreatitis ECG may mimic myocardial infarction. This is an example of acute inferior wall myocardial infarction. You can see the ST elevation in lead 2, 3, and AVF, ST depression in lead 1, AVL, V1 to V6. So these are called reciprocal changes, and this is the primary ST changes. So this patient has acute inferior wall myocardial infarction, should be either thrombolized or subjected to, primary angioplasty. Another example, a person with chest pain, ST elevation in lead 1, lead V1, V2, V3, and V4. And this with ST depression in lead 2, 3 AVF. So ST elevation in the anteroseptal leads, ST depression in inferior leads, reciprocal changes, some J point elevation in AVL. So it is a evolving acute anteroseptal myocardial infarction with reciprocal changes. Again, should be subjected to either thrombolytic therapy or primary angioplasty, whichever is available. Nomenclature of the different myocardial infarction: lead 1 AVL V5 V6 lateral MI, 2, 3 AVF inferior wall myocardial infarction, and V1, V2, V3, V4 anteroseptal. Now this gentleman presented with chest pain and substernal pain, hypertension, hyperlipidemia, and ECG was obtained at the posterior part also, V7, 8, and 9, because initial ECG showed ST depression in the anterior leads. Standard ECG did not reveal any ST elevation. However, when the leads were placed at the 7, 8, 9 situation, then we could pick up that patient has a circumflex occlusion MI, and this is post-angioplasty. So in a suspected myocardial infarction, when the ST depression is there and you are suspecting an acute MI and not able to get the ECG changes, always advise that take the posterior ECG or lateral ECG. It is always advisable. And inferior MI.
That is one of the causes of a normal ECG with MI. Actually, you're not
correct. Correct. Yeah, it is not normal ECG. We have failure to pick up the abnormality.
Yes, sir.
Yeah. So this is the evolution of the ECG changes from normal to acute phase ST elevation. In hyperacute phase, you may not get ST elevation. You get just tall T waves. Then in hours, you get ST elevation with a R wave height reduction, Q wave beginning to appear. Then in days, you get a T wave inversion, Q wave becomes deeper. Days later, within weeks, ST normalizes, T wave inverted, and weeks later, only Q wave remains, R wave height diminishes, ST segment normalizes, and T wave becomes upright. So very old MI recognized by the Q wave. Remember, the Q wave may be normally also present because of the septal vector lead 1, VL, V5, V6 shows small Q wave. The duration is 0.03 millisecond. That means, and it is less than 25% of the succeeding R wave. ST depression, again, there are several causes of ST depression. This is how it looks. ST depression, either upsloping or downsloping or horizontal. Downsloping or horizontal ST depression is most pathognomonic of myocardial ischemia, and causes of ST depression are myocardial ischemia, non-ST elevation MI, reciprocal ST changes, digoxin effect, hypokalemias, SVT, right bundle branch block, right ventricular hypertrophy, left bundle branch block, left ventricular hypertrophy, ventricular pace rhythm. So we have to have a host of a differential diagnosis. 35 years old female marathon runner with a past medical history of acute myocardial infarction resolved with treatment, myocarditis. 3 months ago, presented with emergency department with chest pain. And this is a pleuritic chest pain, worse in when patient is supine and relieved when the patient is leaning forward. The history is very classical. This is acute pericarditis, ST elevation with concavity upward. See, excepting AVR, most of the leads are showing ST elevation and concavity upwards, so smiley sign, right? This is smiley sign. So this patient is acute pericarditis. And there are 4 stages of ECGs in acute pericarditis. Those who are interested, they can dig into it and deep into it.
The PR segment is also in
yes, PR depression. Yes.
PR segment in AVR.
Yes. Yeah.
That is a very distinctive.
Yes. This one.
Yes, sir.
Yeah. Yeah, that's a subtle. I didn't show it to this non-cardiologist, right?
No, this
so, yeah,
that's okay.
Yeah. So basically, 2, 3. So if you look into the precordial leads, all the precordial leads. Just for example, I just tell you, if you get a ECG like this, ST elevation in all the leads, it cannot be explained by a coronary occlusion. It cannot be MI. Please remember, coronary artery occlusion occurs because of blockage in either LAD or RCA or circumflex. It is always localized. It never in all the leads. In the left main, you will get depression rather than elevation in all the leads, because you will get circumflex occlusion and LAD occlusion. So if you'll get 2 territories, but inferior leads you will not get changes. But here inferior leads also showing changes. And in left main disease, you will get AVR ST elevation. Here it is ST depression in the AVR. So it is not left main. Neither it is acute MI, because it does not conform to a anatomical area. Well, could it be COVID-related MI? Yes, no, it can't be COVID-related MI. In COVID-related MI, again, some of the leads show ST elevation. Like in 2, 3 AVF, you will get ST elevation, and along with, say, V1, some kind of mixture. And one coronary occlusion cannot explain COVID MI. So it is not even COVID MI. It is not even left main. It is not even RCA. What is this? It is pericarditis. It is not a coronary occlusion. And if you get this PR segment elevation in AVR, again, it corroborates. QT interval, very important interval. It is it represents time taken for the ventricular depolarization and repolarization. And it is the effective period of ventricular systole. And QT interval is inversely proportional to the heart rate. And normally we correct it for the heart rate. At the 60 heart rate, QTC and corrected QTC are equal. The rule of thumb is that the QT interval should not exceed 50% of the RR interval. You can calculate this by either Weger's formula or Friedrichs formula, but most of the machines, they give the QT these days. And normal QT interval is 440 millisecond in men and 460 millisecond in women. If it's more than 460, it is abnormal in women. And more than 440 in men, it is abnormal. QT interval more than 500 is associated with increased risk of torsade D point. It's very important from the critical care point of view, and we get hypokalemia and hypomagnesemia and frequent VPCs, and sometimes these patients land up with VT, polymorphic VT, and the causes of prolongation of the QT should be known to us. There could be congenital disorders like Jervell-Nelson or a Roman-Ward syndrome, or drugs, very common, amiodarone, sotalol, antiarrhythmic drugs, tricyclic antidepressant, and SSRI, lithium, methadone, chloroquine, mefloquine, macrolide antibiotics, erythromycin, clarithromycin, quinolones, levofloxacin, domperidone, ketoconazole, etc., and tacrolimus. Others are hypocalcemia, hypokalemia, hypomagnesemia, acute MI, myocarditis, hypertrophic cardiomyopathy, hypothermia, subarachnoid hemorrhage, hypothyroidism. So again, these are the host of causes. Drugs are very important. We should remember that erythromycin, clarithromycin, moxifloxacin, getafloxacin, ciprofloxacin, all and cisapride, etc. They also cause QT prolongation. This is example. QTC 500 millisecond due to hypocalcemia. You can see QT prolonged. This is an example QTC widespread T inversion in a subarachnoid hemorrhage. This is hyperacute phase of myocardial infarction, tall T in the precordial leads. Hyperacute MI and QT prolonged. So acute myocardial ischemia may give rise to QT prolongation.
So just like to add, sir, that in acute intracranial events, you can get a host of ECG changes.
Yes.
Because of intense sympathetic discharge, which causes what is called myocytolysis of the myocardium.
Yes.
That is, so you should not think that a primary cardiac event is occurring. Intra-acute hemorrhage, I think acute rise in ICT, etc., can cause ECG changes like sir just showed you.
Yes.
Carry on, sir, please.
Yeah. Causes of short QT, hypercalcemia, congenital short QT are digitally affected. You can see the short QT syndrome. Marked shortening of the QT due to hypercalcemia. This is in digitalis toxicity, short QT, less than 260 millisecond. And you can see the digitalis affects, inverted tick sign in the leads.
The favorite exam question.
Yeah. Yeah. So these are well-known, very classical ECGs. One scene you'll never forget. Osborne waves. John J. Osborne described patients in 1953, where you get, a positive wave following the QRS deflection, like Osborne J waves. These are the J waves. And the height is inversely proportional to the body temperature, classically seen in less than 30 degrees. And I have also seen here in Delhi, where I'm working, I think 2-3 years back, I had seen a patient who presented with hypothermia, J waves. Sometimes it is seen as a normal variant, as a early reproduction of.
So what is the cause of hypothermia in that patient? Mixed edema, coma, or
hypothermia, hypothyroidism, yeah.
Hypothyroidism.
Yeah, hypo. Elderly lady, hypothyroidism, not cared by the family members. Yeah.
Sometimes in the cold, also beggar, street vendor, they expose, they're lying in the streets and all. That's for one patient.
Yeah. So acute myocardial ischemia, hypercalcemia, Takasobos Cardiomyopathy, left ventricular hypertrophy, intracranial hypertension, any cause may give rise to this. Severe myocarditis, Brugada, and Hasagore idiopathic VF. All these may give rise to Osborne J wave. So by and large, if you see a deflection, accepting that early liberation abnormality, all are abnormal. So we should really work up this patient once you see these Osborne J waves. T wave, very important. Tall T, hyperacute T, inverted T, biphasic T, Camelham T. These are the variation of the T wave. And 5 millimeter is the normal in limb leads, less than 10 millimeter in the precordial leads, the T waves. And T wave is a representative of ventricular repolarization. So T wave abnormality means something is happening during the repolarization phase of the myocardium. And this is what looks like: tall, narrow base, symmetrical peak to a very classical of hyperkalemia. Tall, tented, symmetrical. In myocardial ischemia, they are asymmetric and they are not narrow base. Narrow base means hyperkalemia. So actually, you could really, from the ECG, you could really predict that this patient has hyperkalemia by the morphology: tall, tented, narrow base T waves. And inverted T waves sometimes you get in normal finding in children, and up to 16 years you might get in young adults. Beyond 16 years, we call it persistence of juvenile pattern if it remains inverted in V1 to V3. Myocardial ischemia, Bundrans block, ventricular hypertrophy, pulmonary embolism, hypertrophic cardiomyopathy, raised intracranial tension. All these situations you might get a tall T. A broad T, asymmetric, you get in myocardial ischemia. Biphasic T waves, myocardial ischemia and hypokalemia. So some are positive. In mid precordial leads, if you get biphasic T wave, this is called Whelan's sign and very specific for proximal LED disease. If you get in precordial leads, particularly V1 to V4. Camel hump T wave, that means the second hump, and this is because of the prominent U wave. And sometimes the hidden P wave embedded in the T wave may give rise to this because of tachycardia, and this is because of hypokalemia, and you can get in myocardial ischemia also. So see this, there is a second hump in the T wave. So this is camel hump T wave pattern. U wave, with a small wave, U wave is less than 0.5 millimeter immediately of the T wave, and you get usually in the same direction of the T wave and small, and sometimes you get larger T wave, more than 25% of the T wave, then it is large. And in bradycardia we might see this, and there because of the Purkinje cell depolarization and U wave, prominent U wave you get in hypokalemia, and sometimes you get an inverted U wave during the treadmill test that is specific for proximal LED disease. U wave may be very prominent. You get in bradycardia and severe hypokalemia. Prominent wave may be seen with hypocalcemia, hypomagnesemia, hypothermia, raised intracranial tension, left ventricular hypertrophy, hypertrophic cardiomyopathy. Again, you have to have a differential diagnosis of prominent U waves, drugs which are associated with digoxin toxicity, phenothiazine, and class 1 and class 3 drugs. Even amiodarone can give rise to prominent U wave. Inverted U waves, you might get coronary artery disease, hypertension, valvular heart disease. So they look like this. At the end of the T wave, you get this. So these represent myocardial ischemia. Pulmonary embolism.
Is it correct to say that the U wave normally has the same direction as the T wave, the vector?
Yeah, normally, yeah.
So if it is going the other, then it is abnormal.
Abnormal.
And that is how you distinguish from a bifid T wave, because the bifid.
Correct. Correct. Yes.
Thank you, sir.
Yeah. Pulmonary embolism. The commonest ECG change is sinus tachycardia, seen in at least close to 45% of these patients. It could be complete or incomplete right bundle block, right ventricular strain pattern, right axis deviation, dominant R in V1, right atrial enlargement, S1 Q3 T3 pattern. That means deep S wave in lead 1, Q wave in lead 3, and inverted T in V3, seen in only 20% of the cases. This classic sign is neither sensitive nor specific for pulmonary embolism and clockwise rotation. The classic most specific sign is T inversion in 2-3 AVF with right precordial leads showing V1 to V4 is the most specific sign in P, reported with a specificity of 99%. So if you get 2-3 AVF negative and V1 to V4 negative T wave, and sinus tachycardia, certain that this patient has a pulmonary embolism with a 99% surety. This ECG, very interesting. You can see that, in lead 1, the prominent S. So S1, Q3, T3, the Q wave in 3 and T inversion lead 3. S1, Q3, T3, sinus tachycardia, right axis not right, but right ventricular leads V1, V2, V3 T inversion, and inferior leads lead 3 T inversion. So very specific. And this patient has pulmonary embolism. Again, example S1 Q3 T3 QR in V1 with T inversion V1, 2, 3, 4 up to 4, clockwise rotation, the transition zone in V6, again classical of acute pulmonary embolism. Hyperkalemia, T wave changes, peaked tall T, prolonged PR segment, mild hypokalemia, moderate you get loss of P wave, prolonged QRS complex, ST segment elevation, ectopic beats, escape rhythm, severe, sine wave pattern, asystole, ventricular fibrillation, bundle branch block pattern, fascicular block. So this is how it progresses. Initially it is narrow and then starts widening.
If I may ask one thing, certain patients with hyperkalemia have normal ECG and to sudden VTVF. What is the explanation for this? That some patients don't manifest changes, the classic, and may suddenly go into VTVF.
Yeah. See, normally, if the process is gradual, that means, as for example, hyperkalemia occurring in chronic renal disease, they never go to, emergency situation. Mostly they don't. Whatever they go is mostly, atrial fibrillation, atrial flutter, sometimes bradycardia, but they don't really go to VTVF. Because of the chronic process. It is the chronicity of the process which determines the clinical event. So some patients, they slowly develop hyperkalemia, they don't develop anything much. Some patients suddenly develop hyperkalemia, they present with emergencies.
So the adaptation occurs in a chronic process.
Chronic process, there is some kind of adaptation.
Right.
So this is how it looks like. Initially you get tall T waves, and then Qrs prolongation at the later terminal part you get sine wave pattern and Qrs prolongation. This is how it evolves. So you should be able to pick up at this stage and then treat the patient so that the patient doesn't go. This is one of the conceptual diagram. Hyperkalemia, you pull the T wave, and hypokalemia push the T wave. That's how the potassium does. In hyperkalemia, it pulls the T wave. In hypokalemia, it pushes the T wave and the U wave becomes prolonged. So this is a conceptual diagram you will never forget in your lifetime if you see these diagram once. Hypokalemia, can cause various ECG abnormalities, increase P wave amplitude, P become big, prolonged PR interval, widespread ST depression, prominent U waves in the precordial leads, and prolongation of the TU prolongation, long QU interval. And this may present with like this, and this is a torsade, and obviously this patient had hypomagnesemia along with this. Hyper and hypocalcemia. Hypercalcemia causes shortening of the QT interval, and in severe hypercalcemia, one might get Osborne waves like this. There are some elevation, Osborne waves, ventricular irritability, and VF and arrest. In hypocalcemia, QT prolongation occurs, and the T wave is typically left unchanged. There is no change in the T wave, and the patient may have a torsade in this situation. Hypomagnesemia.
So just to add to that, sir, if you remember, one can remember it, that's the opposite. In hypo, that is in decreased calcium, the QT prolongs. The calcium is increased, the QT decreases. So that is a way to remember.
Yes.
Carry on, sir, please.
Hypomagnesemia, PR interval prolongation, prolonged QT. Hypomagnesemia causes prolonged QT. And hypokalemia also will be same thing. Atrial and ventricular ectopy, and it again shows a lot of ectopic waves. If you get such a ECG, then suspect hypokalemia with hypomagnesemia. One has to correct hypomagnesium also, so that you prevent the, torsade in these patients. This actually I have learned very recently, and believe me, this I learned only because of this teaching program, because I was reading the ECG again, and I'll tell you a story. I used to be told by one of my colleagues that your people, they come do the echo, and in this patient, the first day they gave a ejection fraction of 55%. After 7 days, patient is in the hospital. He became very sick. He's on 2 inotropes. Today, they are telling the ejection fraction is 25%. Either the first one was wrong or this one is wrong. Then I realized both were correct. What happens is, because of a prolonged stress and use of inotropes, there is either myocardial depression or a Takasobos Cardiomyopathy development in these patients, and they present with this kind of ECG changes and myocardial depression also. And spiked helmet sign is a very important sign, is ominous sign in critical care medicine. It is not a cardiologist ECG, it is ECG specifically meant for the critical care team. What you get, some spiking of the QRS. And initially 7 cases were reported from the Mayo Clinic, where they reported ECG changes like in lead 2, 3 ABF, or classically in lead 2, like a spiked helmet. Prussian Army's helmet is a spiked helmet like this in Prussia. So you get these changes. It's called SHS, spiked helmet sign. These patients are very sick, and this patient has a very high mortality. If you get in such a patient, usually you get in sepsis, and either systemic sepsis or myocardial disorder. Mostly there are the young patients, systemic disease and infections, so on and so forth, not a cardiac patient and not a cardiac illness. This is how it looks, spiked helmet sign. And this is an example. This is taken from Circulation June 2020, very recent issue. 35 years aged lady who is a drug abuser, intravenous drug abuser, had a abscess in the right thigh, Streptococcus viridans septicemia, right-sided endocarditis, tricuspid valve endocarditis, multiple septic pulmonary embolism, presented in cardiogenic shock, a septic shock, and patient's ECG was this. Left ventricular ejection fraction was normal, but the ECG showed spiked helmet sign. And then patient was treated. After the treatment, the patient had a reversal of the ECG changes.
So the spiked helmet sign is, sir, with the low EF or with the normal EF? And
normal EF, normal. But they carry very high mortality. This is a marker of high mortality.
Ominous sign.
Ominous sign
with the normal EF.
Yes.
Right, sir. That's very interesting. I myself had not heard of this.
I just learned recently.
Yes. Thank you, sir.
Thank you.
Thank you very much. Yeah. So we'll just conclude now, as we are nearing the completion of time. Sir, this magnesium, the changes with magnesium are well characterized. Like they say, it is same as potassium changes of ECG.
Yes.
That can be taken as the changes of magnesium, severe hypomagnesemia, like severe hypokalemia.
Yes.
Right, sir. So then one question for our audience, young audience. When I was a student and doing MD, I was asked what does the ECG show? So I said, the ECG is normal. So the professor told me it takes a lot of guts to say that the ECG is normal. So because there's so many things in the ECG. Even today, when I say the ECG is normal, I have to think a little. Of course, now I'm much better than I was as a student. So how would you, advise our young people to go about reading the ECG? Any particular way?
I would say that, have a systemic approach. Never jump to a diagnosis in the ECG. Always examine the ECG, have a differential diagnosis in mind, and look into the patient. And ECG always to be interpreted in the clinical context. Now, I learned that ECG may be absolutely normal, patient may be absolutely normal. Patient, the reverse. ECG may be absolutely abnormal, patient may be normal, and the reverse is also true. Patient may be absolutely abnormal, ECG may be normal. So normal ECG does not rule out heart disease. Again, abnormal ECG does not say the patient has a heart disease or any disease. So ECG should be always interpreted in the clinical context. That's the first rule. Second rule, never jump to a diagnosis, have a differential diagnosis. And third rule, never treat the ECG, treat the patient. These are the basic 3 rules.
Right, sir. So I would also just conclude it now. One thing, please look at the ECG. We often miss the MIs in patients. ECG is always done. And patients can present with pain anywhere from the umbilicus to the occiput, and sometimes there may be no pain also. And the ECG after 2 days is seen, and the patient has myocardial infarction, and he has undergone endoscopy, he has undergone CT chest and whatnot. So please look at the ECG when you see the patient. Somebody has to see the ECG when the patient is admitted. I've seen this many, many times.
Yeah.
And the MI is diagnosed after 48 hours, after 24, 72 hours or whatever.
Yes.
So that is very important. And just before I conclude, I would request sir to conclude the session. You see, ECG is not just memorizing the tables. If you read ECG, you will understand ECG. It is something to be understood. The tables, have to be put into the brain, but there is a basic concept to that. And I have read from Braunwald mainly, of course, supplemented from other sources. It's not that easy. So I would recommend the chapter in Braunwald as a basic chapter. It explains nicely, has all the tables, and it's not very elaborate. Nothing unnecessary is given. The rhythms, of course, the arrhythmia part is separate. That is something we have to know very well. And the report that the ECG gives, the printed report, has to be taken with a pinch of salt, because it has been seen there are numerous errors in that. So do not look at the report saying myocardial infarction and that this is myocardial infarction. That has been shown to be wrong to the tune of 30%. So in some studies, because of the software error or whatever has been fed into the analysis of that particular machine. So that is all I wanted to say. And I hand it over to sir to finally conclude this wonderful session. He has taken so painstakingly. He has made so many slides, and sir has spoken for 2 hours. I really thank him from the bottom of my heart, so as to say, for the lovely lecture. Thank you, sir. So over
Thank you.
to conclude it.
Yeah, so it's nice to interact with all of you, and it really, this is a stimulus to reread the entire ECG after so many years. And I also learned a new sign. I just told you it is specific for, the critical care, but it's in SHS, the spiked helmet sign. So there are evolving, even ECG evolves. And just to share, in acute pancreatitis, you might get reciprocal ST changes, and which I reported first time in the world literature. When I was in Safdarjung, I had a publication in 1999 in JAPI. We published then in acute myocardial infarction, you might get ST elevation in the SAM leads and ST depression, reciprocal changes. And this is how, even ECG is a lot of area of research and a lot of interest in many people can really work on this. And as I told you, the last word is that never treat the ECG, treat the patient. Thank you.
Thank you, sir. Thank you very much. So with that, friends, we shall conclude. Are there any questions? I will wait for a couple of minutes just in case you have any questions. There's no question so far. So just if you have anything, please put your question. So I think there are no questions. It has been exhaustive, covering everything. You can go through the YouTube tutorial. It'll be up on YouTube and our channel in a couple of days. So thank you, sir. Thank the audience
Thank you.
for patient hearing. And I thank CIPLA for providing the digital technology. Thank you, everybody.
Thank you all. Bye. Wish you a happy new year.
Happy New Year.